We now have a lot of time for discussion and comments. And so I invite people, there are 3 microphones here. Please come up to the microphones, line up, and we'll call on people and engage in this discussion. Let me just ask the first question while people are getting together. Health departments are complex organizations where frequently people are doing their job, and we talk about silos all the time. People are in silos. And healthcare delivery systems, likewise, are very complex organizations. And much of this work will require multidisciplinary team approaches, which to some extent are occurring. That really wakes people up to that. Much is occurring now in the healthcare delivery system. What advice do you have on how we can sort of engage, encourage, enable, and empower people to sort of look beyond their silo and figure out how to do this?
No, it's a great question. And I think there's a couple of opportunities that are immediate near-term opportunities that we all need to be aware of and leverage them, because the bottom line is that much of our funding is categorical, and many of the jobs that we do, if we choose not to do them to do this work, we have to give that money back. First, you mentioned it briefly, but around the country there are, as hopefully most people know, these state innovation models that are being developed in most states, and there is a huge funding opportunity now out from CMS. These represent a great way to have integration between a public health department and the clinical care system, and because it's new financing, potentially a way to get new resources into public health to make these things happen. So that's one. Second, the Prevent Block Grant funding, at least for next year, was doubled, and the guidance that's going out from CDC specifically allows that money to be used for the first time really for what we're calling foundational capabilities. These are the capabilities that every department needs to have in place, independent of its silos, in order to get its work done. One of those foundational capabilities is assessment and epidemiology, and a second one is linkage with the clinical care system. So there's a modest amount of potentially new money there as well. And then third, I did mention, and others have mentioned, the community benefit provisions out of the Affordable Care Act. Really in jurisdictions, particularly where there's more than one healthcare system providing care to the same geographic community, opens up an opportunity for a health department to work with those community health systems, those provider systems, to create a single community health needs assessment and then operate in a joint way off of that. So without trying to discount what we know about siloed funding, I do think we need to look in our own jurisdictions to say, where are those opportunities right now that would enable us to do something different, because the window is only going to be open for a short time.
So you're going to see some interesting dialogue, because I actually don't disagree, but I would answer it completely differently. And that is, obviously there's a problem with money, but the problem actually isn't with money, it's a problem with vision. And the failure to have the inability to have the money follows the primary failure. So I actually think the first step in resolving this is actually both simple and hard, and that is to actually talk to your health system. I'm not sure how many of you or how many are in an organization that's ever done that. And I hate to ask if you did what the reception was. But I think part of it is actually finding some common ground or some common goals you can do together, and then finding the funding to do that. But the first part is actually establishing the opportunity to work together. Let me frame it a different way, because there are a lot of folks in this room. How many of you are in a community that has, right now, an accountable care organization or a Medicare shared savings plan that you know of? How many of you don't know? You don't have to answer your hand. When I've done this before, most folks don't know. And it's time to actually, the hardest part is, it's not that hard, it's to learn a little bit about what's going on and who to talk to, and then go after the money.
So just to take the counterpoint, I do think that the reality, and you know this, is that in most health departments, even the people to make those first contacts with the health department are tough, with the clinical care system are oftentimes tough to find. There's this very modest but real lack of capacity in most health departments to begin that bridge building.
To make a single phone call?
No. You'd be surprised, actually. I can tell you haven't worked in a health department.
Actually, I've been working with health departments for 20 years, David.
There really, I do think, is a sense in many health departments about a need to develop some capacity. You're absolutely right. I mean, we're playing games here, but I do think that reaching out to the provider community is important, but looking within your own organizations to figure out where you can identify the human resources to actually go beyond a phone call, to sit down and in a thoughtful way figure out where your value is to sit at that table, because you're going to have to convince the healthcare system that you have value add when you get there.
Richard Hoffman from Denver. I like both your presentations. I haven't seen Lloyd. Lloyd was my advisor 32 years ago when I was a resident at Duke in family medicine. But both of them were good. But I wanted to ask you this question because I read a book a couple years ago by T.R. Reid on global health systems in different countries. And so I'll sort of pose this to David first, but what would the neighborhood map look like in Vancouver compared to Seattle? Or what would it look like in Birmingham, England compared to Durham, North Carolina? You know, it's not like the Affordable Care Act is perfect and is going to solve all our problems. It's far from perfect, and I was just, there are, as you pointed out in your slides, David, all these other countries with better healthcare delivery systems than ours. So how do they do in terms of this geographic variation that goes from physical activity all the way to diabetes mortality?
No, so it's a great question. And I think there's really opportunities for huge learnings across countries. In healthcare delivery, we do things in different ways. Arguably, healthcare delivery is not going to be the primary determinant of whether or not people are going to be healthy. It's going to be some of the other things we've been talking about, the human and social services that are available and the community health issues. We do know that if you look across countries, what is it, the spirit world, right? I mean, there is work that shows that health in countries is determined by the degree of inequity that is present, and that's true across countries, that's true within the United States. If you look, and so when you look across countries at some of these other underlying social determinants of health, those institutions that have put in better strategies for assuring that not only the health safety net, but the human service safety net and the community safety net are there, have in general done better. I say that in a paucity of data because I think the kinds of things that we're talking about relative to community interventions to prevent chronic disease are sufficiently new that the kind of global work that we would all like to have done to say, where's the evidence that across countries this is actually working? That evidence, at least in my mind, is not quite there yet. So there's a little bit of a leap of faith here. But clearly, even in the UK, for example, when you go from Edinburgh to Glasgow, you're going from a community that has few health disparities because when you look within that community, there is a robust safety net to a community that has huge health disparities because of a tradition of sort of a landed gentry, poor population that has resulted in discrimination over time.
I just add briefly that some of those countries are actually moving in very parallel or even are ahead. So the first mapping I saw for disparities was actually in Ireland, looking at the GP fund holding model and the resources available. So it's being done elsewhere. And interestingly, it's spreading fairly quickly because the issue of the growing epidemic of chronic disease is not US only. So Canada and the provinces are very much into this. And I'm just back recently from the Toronto Hospital that's looking at, as the tertiary care center, how does it partner all the way out across the province to actually be more effective in preventing illness. So this is not just a US discussion. I agree.
Over here.
Thank you. Good morning, and thank you both for your presentations. I know, understandably, the talk this morning both talks this morning have been focused on ACA changes in public health healthcare integration, but I'm wondering if you could comment on partnerships with other human service agencies as transportation and housing and education that really are focusing on social determinants of health, and how both public health agencies and clinical care can partner with those organizations as well.
Well, let me take a first crack at that. The discussion we had at IOM and then with the playbook is about primary care and public health as two common elements, but those are probably necessary, but absolutely not sufficient. In fact, almost always you'll find a third, especially when you're dealing with some of the more tough problems like obesity. You got to have the schools involved, and as we saw in those housings almost always. Interestingly, we found that, I'll tell a very brief story, that the Justice Department is key, in the police, because in Durham County, I mean, we're pretty small and we tend to know each other. It was the police who pointed out that they were spending several $100,000 per year transporting folks from the jail to the health system and back again. In fact, there were a group of folks who had major medical problems, and they were only felt safe in the jail or in the hospital. So leaving aside all issues of housing, where you could put them, we're spending huge amounts of money in transit and transportation of those two. So we're now actually have a program we call Familiar Faces. They're sometimes called frequent flyers. I think Familiar Faces is better. To actually look at how do we coordinate across multiple agencies to actually help people stay safe and healthy. So I think your point's absolutely on target.
Just two additional comments. First, as I do think that governmental health departments, because the fact that we're part of the government, have a unique opportunity here to serve as a bridge between the healthcare system and other organizations, entities in the community that may also have a government relation, for example, transportation or parks. And so I think thinking about how we can catalyze the relations that need to happen because of the fact that we do have a foot in the clinical health world as well as a foot in the government world is an opportunity. Second, when we start talking about work in poor communities, there is another sector out there that I historically have been oblivious to, which is the community development sector. There are huge amounts of money, both government as well as commercial money, that are designed explicitly to improve the economics of poor communities. Historically, those programs haven't worked, and I think most community development folks would say they have been ineffective in solving poverty. But historically, those programs have also really not looked at the intersection between health and community development. There's a burgeoning interest in that right now, sponsored by San Francisco Federal Reserve, but also RWJ. And so would really be looking in your communities to make best friends with your community development corporations, which go by the acronym CDC, by the way, so you're feeling allegiance there. But that really represents, I think, an opportunity for the future.
Middle here.
Thank you. Lorna Thorpe, New York City. I wanted to see if I could get you back sparring about how public health can engage the health sector. And I think both rural areas and urban areas both have challenges in doing so. But in urban settings, and I think, Dave, you alluded to this earlier, in urban settings, the concept of an accountable care organization is a very different thing. You have multiple health sector institutions. You have public and private healthcare delivery, and you have a lot of competition. And so engaging that healthcare sector is really challenging, both from the data perspective in compiling those collaborative analytics, but also in the intervention space in terms of improving care. It gets very competitive. And I wonder if you have advice, and probably from Portland you do, on exactly how this has played out in a good way from what you've seen nationally.
So I think we need to recognize that the healthcare system, particularly in jurisdictions where there are multiple systems, naturally, as you're saying, there will be some degree of competition. And to just acknowledge that that's part of it. But then also to say, where are the places where it makes sense for organizations that are competing to collaborate with each other? Because just because you're competitors does not mean that there are no opportunities for collaboration. The two that we've tried to capitalize on in Seattle are first recognizing that as patients become more and more complex and as their needs move a little bit away from the clinical needs that the healthcare systems are designed to deal with to the human and social service needs that at least historically they have not, that there does become an economy of scale at some point potentially for the most complex patients to be managed by a system that is not competing against each other, but rather as a single system that knows how to link patients from multiple different competitors into the same set of services. So that's one area where I think there's a real opportunity, a near-term opportunity. The second, and I may be cavalier on this, but I do think it's this community piece. In general, when you have multiple systems competing, they tend to be drawing people from the same neighborhoods. And so the only way, really, to get interest and investment in those neighborhoods is for people across competing systems to say, gee, I'm going to compete with you on the clinical care piece, but on that neighborhood prevention piece, the only win here is for us to jointly recognize the problem and jointly invest so that our dollars, because we can't direct them only to our patients, are going to the communities where all of our patients are coming from. And that sometimes works.
And if you're looking for sparring, we're actually going to agree. I'm just going to add another degree that part of what helps is to have the health system, is to ask the health systems whether they want to compete on everything or whether there are opportunities for collaboration. Very few health systems make significant money on Medicaid, and nobody makes money on uninsured, even though those numbers are dropping. So part of it is being able to talk to the CFOs about the opportunity to actually collaborate in some areas and compete like crazy on the high-end stuff they make the money on, and being able to segment the market, to use that terminology, turns out to allow you to actually break through those barriers. You also, though, back to language, you have to learn some funny language. The one I had to learn is being able to talk about the variable contribution margin per Medicare occupied bed. Whew, I almost can say it in one mouthful. So that you actually can talk finance to the finance guy and actually make the case, look, it does make sense to collaborate around community prevention and interventions because it's ineffective and inefficient to do it in a competitive model. And then they listen. And they go, why didn't you tell me that a long time ago?
Tish?
Yeah, hi, I'm Tish Davis from the Massachusetts Department of Public Health. I just want to share a recent study that was published that was really kind of heart-wrenching, and it's a study of hotel housekeepers who all with diagnosed hypertension, and on interview it found out that they don't take their diuretics because they can't use the bathrooms that they clean, and they don't have time in their work schedule to go the 24 stories below to use the staff bathrooms. So my interest and traditional interest is occupational health, work-related illnesses and injuries, but it's become increasingly clear to me after 30 years in the health department and watching many of our chronic disease programs that an understanding of people's work lives is really critical in managing chronic disease, independent of traditional occupational illnesses and injuries. So my question of you is if any of these community models or community health needs assessments that you know of have taken work into account, because I think that would be a really exciting prospect. And if they haven't, if you have any recommendations how we can encourage collaboration between you folks and those of us in the occupational health community.
Yeah, that is a wonderful point, too infrequently made. There are some good models, Rochester, New York, I'm not sure if anybody's here from there, where they got the major employers involved in the discussion. And pulling in the workplaces or either to make it less destructive or more positive can be incredibly powerful. There's another hotel story, though it's Florida-based, where they actually looked at these women who weren't getting enough exercise and said, wait a minute, they're cleaning rooms. That is exercise. How do we actually help do the exercise in ways that actually may help them maintain their weight without hurting their backs? So they actually turned it into a benefit package for the employer around the health of those folks. Doesn't answer the issue about going 24 stories down to the bathroom, though. I don't have a good answer to that one.
The only thing I'd add is that when we're thinking about potential partners out there, there are the employers in a jurisdiction, particularly the self-insured employers who tend to be larger, oftentimes offer better wages, of course, who are fronting much of the cost of the system that we currently have. And so when we're thinking about, at least in Seattle and King County, when we're thinking about who are the advocates we can get out there from the business community to say, yes, there does need to be a change in the way that we are doing business in healthcare and moving to a health system. It's the employers who are paying for our current inefficient system and enlisting their help in being advocates, and because they have the power of the purse in moving smart policies along is something to think about.
Denise?
Denise Q, CDC. And I think too, David, your point about human resource issues, and I think that the action is definitely at state and local level, but CDC is trying to also engage in this space of public health healthcare and really to try to support our public health partners. But we don't have a lot of human resources also, people who are thinking about this issue of public health healthcare. So for those who are wondering what my role is, since it's changed 3 times in the last few months, I was moved to the Office of the Director of the Office of Public Health Scientific Services to work on health systems issues, but immediately got loaned to the Office of the Associate Director for Policy, and wanted to clarify the point that Lloyd made, which is that we are in the policy office working on this community health improvement technical package, and hope to put this out by the end of the year to take advantage of the fact that the hospitals are going through their next IRS tech cycle in 2015. And indeed, to David's point, we are really trying to include among the elements of this technical package, which I won't try to talk about now, a table of the potential partners to include. Those would be hospitals and public health, but also community development corporations, community action agencies, United Ways, other organizations, because they're out there, as you pointed out, very interested in health. And in fact, the policy office is organizing a SOCAP meeting, social capital meeting in New York City for later this week to really engage folks. And then the other thing I would say, federal government is slow to move, admittedly, in innovative ways, but I'd have to say that after 23 years in the government, there is more collaboration going on at the HHS level than I have ever seen. Our new Secretary Burwell called together the various different parts of HHS just recently, and she asked for their highest priorities, and she thought they had too many priorities. There were 7. But one of the things she said, cut it down. And one of the things that Patrick Conway from CMS said, that one of the top priorities has got to be population health. So the fact that CMS and CDC are having these kinds of discussions, and that the next rounds of funding from CMS is indeed further going into the communities, really gets to your message. Get out there, partner with folks, be ready, because of the fact that there are opportunities coming from both federal government and foundations, et cetera. And that is an advertisement for our session at 10:30, where the Oregon, New Jersey, and Nebraska state epidemiologists will be talking more about what they're doing in this space in the new health system.
Juanita?
I think there have been data related to the decline in emergency department visits when there are outreach workers going out into the community. I think I remember maybe more than 2 years ago seeing in the lay press an article something like what Mississippi can learn from Iraq, or something like that, when Iraq was mission accomplished. Anyway, so whose job is it to get the ball rolling? Is it the facility or the local health department? Are there federal incentives that need to be created?
Actually, that's a great point. When we looked at what worked around the country, the stories, there was no pattern. Sometimes it was the health department, sometimes it was a primary care group, sometimes it was a person who didn't have any of those hats. The one thing that was constant was that there was somebody who cared. And it goes back to the issue about how does this start and how does this sustain us. Every single one of those successful examples had a story of somebody who cared, didn't have the time, but moved ahead anyway. It goes back to, actually, I'm not sure I want to quote sociology to a group of epidemiologists, but it's Margaret Mead, about never underestimate the power of a small group to affect change. In fact, it's the only way change ever occurs.
I would just add that we're fortunate, I think, to live in a world that, while it's changing, it's full of rational people. And so as people are struggling for solutions here, there really is power in the good idea and power in the innovative idea. So it doesn't really matter so much where somebody comes from as much as the smarts behind what it is that they're saying, including the smarts to recognize that this is a business that we're dealing with here, and therefore integrating the health outcomes with the money outcomes and looking around the country and around the world for where have there been proven solutions that can be adapted and adopted. Coming to the table with a good idea, but a good idea that's backed with a little bit of data or a rationale is really the way to get the seat.
Megan?
Megan Davies, North Carolina. First, I want to thank you both for your presentations and say that I kept thinking as you were speaking that I wish I could make the kind of case that you both appear to do so easily with that kind of power and conviction and strength of presentation. You know, I feel like I could change the world if I could do that. So I appreciate you doing that for us this morning. I have a question about just exactly what you were just talking about, David, of making the case economically, fiscally. And some of those, Lloyd gave several examples of very quick turnaround benefits that didn't always save money, I think, but showed benefit. But when I thought about those maps you showed us of Seattle, King County, and the inactivity leading down the road 20 years later, how do you get commitment to change that situation that is going to pay off in big ways 20 years from now? That's always been a challenge for us in public health.
So I don't have the magic answer. The two overt strategies that we use are, one, to appeal to people's desire for their kids to be in a world that is healthy and safe. And so as you're talking about these long-term outcomes, to remind people that it's not about us, it's about our children. Second, and maybe more practically from a business sense, I don't have enough money to invest in anything, but I do know that when I listen to folks that they always say that the key to successful investment is a diversified portfolio. And so as we're trying to come up with where are the smartest investments that we need to be making upstream in prevention, we need to follow that financial wisdom and make sure that we're putting some of our money in those downstream, close to fruition kinds of things that will yield immediate returns, but at the same time to recognize that we would be short-sighted if that's all that we do, and we need to put a piece of our investment in those upstream activities that in many instances are going to yield better health and potentially economic returns over the long run.
This is a yes and. But I think part of it is to frame this as an issue of relationship and trust, not just about outcomes. This is about forming partnerships that can prevail and be sustained. So if you're partnering with financial folks in the healthcare system, they want to see a payoff. So do something that can do that. Maybe overly medical in your eyes, but if fine, start. But don't only do that. So this is about how do you start from one and then do a second and then do a third. So you have a portfolio of projects. Yeah, I couldn't agree more. And obesity, those long-term projects need to be on there. They just may not be the best one to lead with if you don't have a history of working together because of the trust and relationship issues.
Andy?
Hi, Henry Henderson from Wisconsin. We tend to think of the healthcare system as kind of a monolith, and when you said make a phone call, my question would be, where do you see the greatest receptivity within the bureaucratic healthcare delivery system model? At the state level, often our main contacts are on the Medicare side, and that's often, at least in Wisconsin, not a very friendly relationship. So the person who's at the table negotiating with the state for Medicare is not necessarily the best person to reach out to for, gee, we really like you to help us. So what's your experience of if we're making that call, where's the greatest receptivity to the public health message outside of the baggage that comes with the being state government?
That's a wonderful question. And by the way, I get asked it by the primary care folks who say, well, who do I call in the health department? I go, well, you could look it up. But that said, all politics are local. So the key issue is to know somebody who knows the community who can guide you in. One, Medicare and Medicaid are obvious, Medicaid in particular, but another one is that most states now have a CTSA grant. Now that, for those who don't know that lingo, that's the Clinical Translation Science Award of the NIH, and one of its pillars is actually engaging with communities. So Wisconsin happens to have 2 CTSAs, and they have 2 CTSA community engagement leads, both of whom are quite good and know their local health system. So that's another way in, but I'm not saying that's always the right way in. By the way, it'd be good for Vanderbilt too. But it's learn, touch base with folks and find out the right person. They're always there, but it's something, I made it sound way too glib, of course. But it does take a little bit of sleuthing to figure out who to call, who actually would answer the phone and be polite.
Absolutely agreed, and we just, it probably goes without saying, but our work is about relationships, right? And so if the first call is a call that is this directive, it may not be as successful as thinking about who are those key movers and shakers in the healthcare system in your jurisdiction, and how can you find a way to meet them without necessarily having it to be a cold phone call, and create those relationships between folks in your department and folks in the healthcare system, because ultimately it's those relationships that are going to determine how successful we are.
Jeff?
Jeff Engel, CSTE, and again, I'd like to thank you both for coming today, and I know you're very busy and you have to fly out immediately after your presentations, but thank you so much for coming to our first plenary for 2014 in Nashville. My question to both of you is, we have many MPH graduates here in our Applied Epi Fellowship program. From your clinical perspective and your health department perspective, are the MPHs that are coming out today prepared for this integration? What would you, if you were a dean of a school of public health, what's...
Is this on the record?
Absolutely. Because when I talk to the deans informally, they think they're doing a great job. From my lens, I think some of the analytics that these master's level people need to learn, they're not getting. Particularly the people who have a concentration in epidemiology.
Well, fortunately, we all know that there is nothing like someone who is vibrant, young in their career, with innovation for us to be successful. What I'm trying to say is we're in a time of transition, and almost by definition, the people who are teaching the courses in these schools are not the people who actually are going to be able to figure out the changes that need to be made. It's the folks that they're producing, these young people. So there are huge opportunities out there. And no, probably everything that you learned in MPH school is not what you're going to need to be successful, but the skills of being innovative, of trying to be data-based, of knowing how the system works will serve you well. And I would say that there's huge opportunity here, but in particular, moving into some of these areas where there's these old workforce, many of what you see around you don't have, which is this knowledge of both the public health and the clinical care system, which has been lost over time, which is the knowledge of the economics of healthcare delivery, which is actually the knowledge of community development and how you begin to think about making deals in the community that transcend health into issues around transportation and parks and food. That's where the action in the future is. And all I need in my health department are really smart people coming out of the University of Washington who have that as their goal. And the training is something they can figure out.
We're at time, and I actually have nothing to add.
I just want to thank the speakers for a really extraordinary discussion of a critical topic. It was really terrific. Thank you.
Definitely what he was doing. Thank you. I left your